Hello, today we are going to talk about white dot syndromes, and especially first, for us to have an overview, we have the six most important white dot syndromes that are more prevalent in women, also showing a decrease in visual field, photopsias, and affecting the outer retina. So we have to think about multiple evanescent white dot syndrome, acute macular neuroretinopathy, paracentral acute middle maculopathy, multifocal choroiditis panuveitis, punctate inner choroidopathy, and acute zonal occult outer retinopathy. Although we know that the last one is not as occult as we thought earlier. From those six white dot syndromes, we will focus today in a clinical case of MEWDS, of multiple evanescent white dot syndrome. It is actually a very typical case, but we will show images that are very comprehensive and give us a very broad idea of ancillary tests that help us to make proper diagnosis. As we talk about white dot syndromes, just to complete our overview, it's important not to forget in the differential diagnosis two rare and aggressive forms of white dot syndromes, which are acute posterior multifocal placoid pigment epitheliopathy. And this one really calls our attention very much because this one can also be associated with cerebral vasculitis, which can kill the patient, and therefore it is the most important one. And serpiginous choroiditis, which has also a more severe prognosis. And the last one that we also have to think in our differential diagnosis is birdshot uveitis. So now I want to present you the clinical case of MEWDS. And when we think about MEWDS, we have to remember that it is more prevalent in women in a proportion of 4:1. In other words, 80% of patients are women and just the remaining 20% would be men at a young age. Generally from 15 to 50 years old, but more prevalent earlier in life. And unilateral, where the patient shows photopsia, can also have color vision impairment and affecting central vision and also the temporal inferior area of the visual field. It has a very good prognosis, and since it is evanescent, it means that the white dots that we see at the retina, they will fade over time, and visual acuity will improve without any necessity of drugs, of prescription drugs. And so our case is of a patient, a female patient of 16 years old, and her chief complaint is a low visual acuity on her left eye. She says that at day one, she started having a headache just on the left side. It is not a migraine because she doesn't have any type of discomfort with light. or with sounds while having that headache on her left side. And associated with her headache, she also had malaise. And at the second day, her headache has gotten worse, and she started having also the malaise also got worse. But when asking her mother thought that her malaise and her headache should probably be associated with her period, since she usually bleeds a lot. She has a lot of discomfort in her periods. So in the first 2 days, mother and daughter, they thought it was related to her period. But on the third day, when she was taking her shower, she saw, actually she was not seeing her left armpit clearly, and actually she was not seeing quite of her armpit. And then she started to worry, and later that day her central vision also started to get worse. And on the fourth day, her visual acuity got even worse. And then on the fifth day, they decided to go to the medical doctor, to the ophthalmologist. And they did some tests, retinography, autofluorescence, but without a clear diagnosis. Then on the 22nd day, I had the opportunity of examining her, and actually when I saw her, her visual acuity was already better, and she hadn't taken any medications so far in these previous 22 days. And I continued to see her, and by the fourth day, her visual acuity was even better. So actually, just to show you the visual acuity improvement, we can actually see that in this graph, on day 1, her visual acuity was 2200. On day 22nd, it was 2063. On the 31st day, she was 2040 on the left eye, and on day 39, she was 2032. So almost getting better, almost completely recovered. And of course, in her right eye, vision was completely normal. And when we see her retinography, and this was done on the 22nd day, we actually, if we look quickly, we may not see some signs that point that something in her left eye is not right, is not okay. So we can actually appreciate here that surrounding the left optic disc, we have a area that is kind of greenish, whitish, and very different from what we see around the right optic disc. And also, when we look at the fovea, we can see that there are some yellow dots in her fovea, which are actually also not normal. It is different from the left eye. We don't see very clearly white dots here, but because of course it's evanescent, and here we have 22 days, so the areas with white dots, they are not extremely apparent here. And then when we look at a single photo of her left eye fundus, then we can actually appreciate much more the foveal area with a kind of a reticulate kind of yellow points surrounding the foveola. And there are some signs of where the white dots were in her retina. And to more thoroughly appreciate those white dots, we can do a fundus autofluorescence, which will reveal in a much better way those where the white dots were, and where they were we can still see a hypoautofluorescence in the fundus autofluorescence test. And also we can very, very easily see that around the left optic disc, we can see those lots of black dots, also in a reticulate pattern, showing hypoautofluorescence. So now we can see that it's very, very, very straightforward to look and see the result of the inflammation in the left eye. And if we do a visual field test, we expect to see that because of that hypofluorescence around the left optic disc, we should see an increase in the blind spot in the left eye. And this is exactly what we can see here when we do a semi-automatic kinetic Goldman visual field. And actually measuring the area of the blind spot, we can see that the area is 231.5 square degrees in the left eye versus 9.7 square degrees in the right eye, which is around 24 times higher in area in the left eye. So this is a test that we can use to measure improvement over time. And it's very interesting to see that visual acuity will improve much faster than the increase in the blind spot. So how long will the blind spot take to go back to its normal area? So this is a test that will actually show us. I will follow this patient and I will tell you if it takes 2 months, 3 months, a year, let's see. Okay, so this is a very interesting test. And also when we check the OCT of the left eye, we can see in the outer retina a lesion, an elevated lesion measuring 200 micrometers and with a height of 40 micrometers, as we can see here in this slide, which probably is responsible for her visual acuity not being perfectly 20/20 at the moment. And so this is a very interesting, very typical case of MEWDS. And I have a few commentaries to make. And as we can see, it's a case that one thing that is very important here to see is that the patient had viral prodromes. She had the malaise, she had a headache, and this is very interesting because there is no disease that is solely immunologic and no disease that is completely solely infectious. Normally, we have both in a greater extent, it can be almost completely immunologic. In a greater extent, it can be almost completely infectious. In this case, we have a typical disease that is mostly immunological, but we have the viral symptoms. So most likely, this type of disease has a trigger that is of some type of virus. And doing here a little bit of thinking, we know that the herpes viridae family has a high affinity for the retina, especially HSV1, HSV2, CMV, EBV. So when I did serology for those virus, I could see an increase in EBV and also an increase in HSV1. So there is a possibility that the trigger was a immunological reaction to those viruses. The patient had already done a screening test for other infectious diseases, and everything was normal. So, under the light of genetics that we have nowadays, with genetic panels, including immunological panels, especially panels about genes that, when mutated, they show a higher susceptibility to uncommon immunological reactions. So those kind of genetic panels, immunogenetic panels, are genetic tests that I really encourage you to do nowadays. They are very recent, but for example, for the herpes viridae family, we have nine very important genes that when mutated, they can make our patient react differently, showing some type of immunological alteration in different parts of the body. So maybe MEWDS is, maybe we will be surprised if we do those panels and we find that maybe there are some of those 9 genes that, when mutated, they can be more, they can show us some kind of mutations that may be more prevalent in this type of patients. So we will only discover that if we start thinking about that. So this is one consideration that I think that is the most important one in this case, since we are talking about a diagnosis that is not that hard to do, because it's not extremely rare. It's not very common, but it's not rare. So this is the consideration that I wanted to make. Thank you. Bye.